Hello friends, today I am going to talk to you regarding the dermatological diseases that are manifesting oral cavity. Oral cavity happens to be a harbor for many diseases. Incidentally, over 1,000 diseases can be found in the oral cavity, whether it is bacterial, viral, fungal, or it is associated with detailed uh, debilitating conditions that could be manifested due to systemic influence. Today, the drugs have been a very major cause for alterations in the body resistance. And when we take drugs for a longer time, you'll find that there can be lesions found in the oral cavity also associated with that. Sometimes it can manifest in the form of allergy, sometimes it can manifest as a change that can be attributed to the drug metabolites which can get deposited in the oral cavity and in structures. I'm afraid to tell you that many people suffer from various diseases, but still they don't go to dentists for their examination. A time comes when that leads to severe impairment in their functions, and finally the students are slowly looking at the lesions for a longer period of time. So I am going to today present to you various conditions that can manifest in the oral cavity. Thank you. Good morning, ladies and gentlemen. My topic today is dermatologic lesions and their influence on the periodontium. Incidentally, I am going to speak to you on different aspects, as in the form of introduction, terminology, discriminative gingivitis, dermatologic lesions, herpes simplex virus infection, varicella zoster virus infection, erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis syndrome, followed by Behçet's disease. And we will complete with pemphigus, pemphigoid linear IgA disease, oral lichen planus, chronic ulcerative stomatitis, dermatitis herpetiformis, lupus erythematosus, psoriasis, and finally we will conclude. In different situations that can occur, a thin oral mucosa could be there could be a vesicle, there could be a bulla, there could be a ulceration, there could be a trauma that could be followed by infection, and that could lead to a different type of various lesions that can occur. Incidentally, any lesion can begin with a macule. Macule is a small elevation on the surface of the mucosa. That will be followed by a papule. Papule will be a situation where it could be elevated from the surface of the skin or the oral mucosa, and it could be associated with a small lesion. Plaque is supposed to be a small scaly lesion that could be present on the surface of skin or the epithelium. A vesicle is a fluid-filled small blister which can appear in the oral cavity or also in the skin. This vesicle can get enlarged to form a bulla, and once the bulla can occur, it can get filled with pus also, and that will lead to a pustule formation. Eventually, when this thin layer of epithelium or epidermis gets disordered, you will find that there is an erosion, and that could be followed by an ulceration that can take place in the situations like oral cavity or in the surface of the skin. Sometimes you will find that there will be a blood collected in the skin or in the surface of the epithelium, which we call it as purpura. Now, these are some terminologies which I wanted to tell you before we start these conditions. The first and foremost thing that I would like to tell you today is the desquamative gingivitis. Desquamative gingivitis was first reported in the year 1894 by Tomes, and the term desquamative gingivitis was coined by Prince in the first person who wrote a textbook in oral pathology in the world. Probably he is the man who is supposed to be honored in a larger situations. Now, this desquamative gingivitis was also called as bullous mucous membrane pemphigoid. As you know, this lesion could be associated with an erythema or redness, which will be associated with desquamation, and that will be followed by ulceration, as affecting associated with various changes, and it could not be associated with a sort of gingival response, but it could be associated with some various conditions. Now, ulcerative changes or desquamative gingivitis could be associated with oral lichen planus, cicatricial pemphigoid, bullous mucous membrane pemphigoid, or it could be associated with LAD, dermatitis herpetiformis, or it could be associated with lupus erythematosus, or even chronic ulcerative gingivitis. Now, as I was telling you, these are the situations that can come up. Okay? Now, what exactly happens in situations like herpes simplex virus infection? You will find that herpes infection could be manifested as a result of virus, that is herpes virus. There are 9 different types of herpes viruses which could be associated in the oral cavity. It could be associated with a viral genome code, could be a nucleocapsid, could be a integument, or it could be an outer envelope of glycoproteins. Now, once the lesion is ulcerated or maybe due to injury, you will find these viruses can enter into the body. It could be oral mucosa, it could be skin, it could be eye, and that could be associated with a primary infection. You will find that there is a certain period of latency. We call it as neural latency, and there could be an epithelial latency also. Eventually what happens is there will be changes taking place in the oral epithelium. You will find that the nucleus of this epithelium can be invaded by the viruses, and you will find that there is presence of various changes that can take place in the form of multiple vesicles which can form, and that other vesicles can fuse and which will be painful and which will be tender in percussion. Of course, you will find that the lesions can occur on the marginal gingiva or papillary gingiva and can manifest in severe amount of pain, fever, difficulty in swallowing, and you can find that the lesions can be present also on the lip or the lower lip and the buccal mucosa. Incidentally, you will find that there are different causes for these changes. As I was telling you, there could be fever, and as a result of ultraviolet radiation, you will find that the person can get infected, or it may be due to stress, or it may be due to menstrual cycle, or it could be a trauma also which can cause the invasion of these viruses into the oral cavity. Many a times a patient who undergoes scaling process or oral prophylaxis, he comes back to us and complains that he has got severe pain and difficulty in swallowing and feverish in nature. When we look at his mouth, we will find multiple pinhead-sized vesicles which could be a characteristic feature of herpes simplex. Now, this activation of latent virus can occur, and that can result in recurrent type of HSV infections, and that can lead to recurrent herpes labialis. Now, as I was telling you, the lesion can also be present in the angle of the mouth, and then we call it as cold sore or herpes labialis. Situations can occur in the form of recurrent nature, which could be herpes labialis. Situations will be there: itching sensation, tingling sensation, burning sensation, and that will be followed by papules, vesicles, ulcers, crusting, and resolutions. And you will find that if you do a lab investigation, the cell culture is the best method or gold standard by means of which you can try to find out the presence of the viruses, maybe by inoculating it in the eye or in the allantoic membrane of rabbit, or it could be chick. Similar smear layer studies can be done by Zang cells. You might be aware that Zang cells are supposed to be large cells which has got a larger nucleus,
and you will find presence of these intranuclear eosinophilic bodies which can be present in the zinc cells, which are characteristics of viral infection viruses. Also you will find that there could be an elevated IgM levels, and that could be associated with a seroconversion of elevated IgG. You can find the lesion on the surface of the lip, and you can see how the multiple lesions that are occurring in the palate, which are associated with herpes simplex infection. And you can see the viral particles on the right side, how they are stained in zinc cells. Well, how do you manage this HSV infection? Usually the primary herpes simplex infection could be associated with use of pain control and also supportive care, hydration, and you give antiviral drug acyclovir 15 milligrams per kilogram body weight 5 times a day, okay, and it should be carried for about 8 to 10 days. Of course, if it is a recurrent type of herpes simplex infection, you can do a reduction in the triggering factors, use topical antivirals like acyclovir creams, or use some systemic antiviral drugs like valacyclovir 1000 milligrams 3 times a day. Apart from that, you will also find this another condition which is called as varicella zoster infection, VZV infection, where you will find that it could be characterized with chicken pox, and sometimes if it gets reactivated, it becomes blared up with a situation called herpes zoster or shingles, which is supposed to be still a dangerous condition. Incidentally, the herpes zoster infection usually is characterized by a primary lesion with prodromal symptoms, maculopapular rashes. You have a dewdrop, vesicle, red fever, malaise, and intensive pruritus. Itching sensation will be there, and you will find that these lesions can be associated in the form of along the pathway of the nerve. So you will find that this lesion does not cross the midline. However, there's a characteristic feature of zoster infections. You will find there's a prodromal situation, and you will find crops of vesicles, zosteriform pattern, which could be noticed. Apart from that, in the oral cavity you will find this sort of primary infection, which will be minor ulcerations. Shingles could be associated with a sort of uncomplicated common changes, and you will find there's a Ramsay-Hunt syndrome, which is where they are associated with Bell's palsy, and there is a vesicle of the external ear and retard sense of loss of sensation, and that of the anterior two-third also, because there is the involvement of the vestibulocochlear nerve also, especially the 8th nerve. Sometimes you will find that the shingles can occupy any of the three divisions of the maxillary nerve. It could be an ophthalmic division, or it could be a V2 or V3 involvement, and there will be a post-therapeutic neuralgia. It could be associated with a mandibular division also in the same way. Shingles may be associated with the exfoliation of teeth, and bone necrosis sometimes can occur in HIV patients also. And here is a situation which will manifest the presence of herpes zoster in the palate, as you are seeing the presence of the palatine area. At the same time, you will find there is also a lesion present on the surface of the palate. Okay? Now, this is a situation where you will find that the treatment could be associated with as similar to that of the HSV infection. You can give painkillers like aspirin, which may be to some extent, you can avoid it. You can find out some sort of a Raynaud syndrome and could be avoided. Ibuprofen is the best choice for this situation for pain. Of course, post-therapeutic neuralgia can be treated by as a first line of treatment using gabapentin, and then associated with 5% lidocaine patch, which can reduce the pain. Second line of treatment is opioid, analgesic, and tricyclic antidepressants. Sometimes there is a chance that you can have a vaccine, live attenuated vaccine for varicella could be a very useful one to reduce the outbreaks. Erythema multiforme. This is supposed to be a very interesting lesion which could be associated as a result of drug which has caused allergic reactions and can bring about such conditions. Now, erythema multiforme could be of different types. It could be minor, it could be a major type, it could be associated with Stevens-Johnson syndrome, or it could be with that tense. Of course, there are different types. We have got acute type, the self-limiting type, and the inflammatory type, which can be manifestation. The cause for it, as a matter of fact, I was telling you, could be an allergic reaction or hypersensitivity reaction. Could be associated with HSV virus infection. Drugs like NSAIDs, anticonvulsant drugs could be a situation. Sometimes drug preservative or food preservatives like benzoic acid can bring about such allergic reaction, and that could be manifested in the form of HSV antigens, and there could be a T cell hypersensitivity reactions, and that will production of interferon, and that will be associated with epithelial cell destruction. All these situations can be manifested as a result of immune complex vasculitis. As you know, we have a condition where it's called as anaphylactic reaction will be taking place. Now that could be followed by complement fixation, leukocytoclastic destruction of the vessel wall will take place, the vascular obstruction will be there, and that will be followed by ischemic necrosis of the epithelium, and you will find that there is epithelial cell destruction. You can notice these lesions can occur anywhere in any part of the body. It could be in the hands, it could be on the face, it could be anywhere in the body. Okay, it can affect age group anywhere between 20 to 40 years. There will be a prodromal situations like maculopapular lesions. You will find a centripetal movement. Hands and trunks anywhere in the body can be affected. You will find there is a target lesion or iris lesions, which you will be finding that there is a blister, central blister or necrosis with concentric rings of variable colors that can be manifested. You can see in the palm how the lesions can occur. They are called as target lesions, or sort of bullseye lesion as they are called. You will also find in the oral cavity mild erythema, mild painful ulceration, site is usually the lip or the lateral border of the tongue. You will find blood-stained saliva, difficulty in chewing and mastication. You can find the lesions to be very, very painful and very difficult for you to treat also. Laboratory investigations and histological evidences, there is no specific investigation for this allergic reactions because Stevens-Johnson syndrome, but you can also find immunofluorescence examination could be a negative one. The diagnosis is typically based upon the clinical features, and there could be a liquefactive degeneration of the epithelium. You can find intracellular vesicles, you can find acanthosis, pseudoepitheliomatosis, hyperplasia, and necrotic keratinocytes. The lamina propria will be associated with perivascular chronic inflammatory cell infiltrate. Now, how do you manage the conditions of Stevens-Johnson syndrome? It could be associated with systemic topical analgesics, supportive care as the disease is self-limiting. Severe cases are treated by using systemic corticosteroids. If associated with HSV infection, antivirals have to be supplemented. Sometimes even dapsone therapy could be of great use, to reduce the side effects. About 100 to 150 milligrams per day can be given. The next one which we would like to talk to you is Stevens-Johnson syndrome, which ends toxic epidermal necrolysis syndrome. You'll find that Stevens-Johnson syndrome is a lesser form of the TANS, that is toxic epidermal necrolysis syndrome. Lesions usually occur on the chest. Atypical target cells can be found, lesions can be found. The Stevens-Johnson syndrome associated with medications or mycoplasma pneumonia rather than HSV infections could be noted. Involvement could be all sorts of mucosa, it could be eye, it could be genitalia, it could be mouth, which can be severely affected. Now you can notice how the lesions are affecting the lid. and supposed to be very nasty, which is affecting almost everywhere in the lip, lower lip, as well as on the sides of the tongue. Here is again another situation where you will find the lip is very badly affected. Well, when we do the histopathology, you will find that there is epidermal involvement. Epidermis sites are associated as a result of deposition of the drug metabolites, and you will find that such situations could be a very, very tragic situation. Incidentally, as I was telling you, the management is associated with severe corticosteroid therapy systemically, at the same time intravenous immunoglobulin therapy, which can be given by the form of interferons, and sometimes even this drug thalidomide can be provided to the patients associated with Stevens-Johnson syndrome and the situations like that. Behçet syndrome or Behçet's disease is associated with pan mucous membrane involvement. It could be genital, it could be oral, it could be Behçet syndrome, or it could be associated with ocular diseases also. Today, it is considered as a multi-system involvement disease. Now, situations could be associated with immune dysregulation, where you will find there is an alteration in the immune or problems of the body. So clinically, you will find that pustular lesions will be found, neurological involvements are there, thrombophlebitis is there, venous thrombosis is there. Sometimes it can affect, as a result of which there will be renal, cardiac, pulmonary involvement, and in the oral cavity you will find the recurring oral lesions. The next disease that we are going to talk to you is about pemphigus. Pemphigus is supposed to be a very, very dangerous, life-threatening disease, which could be associated with a group of autoimmune, potentially life-threatening conditions, and sometimes you will find there is susceptibility to genetically determined certain conditions. Of course, you will find that this lesion is about 0.1 to 0.5 per 1 lakh patients or people, and usually is affecting the 5th or 6th decade of life. In many of situations, people like Jews, they are susceptible for pemphigus because of the HLA-DR4 and TQ8, which are haplotypes, and they are associated with pemphigus. This is because of genetic situations. Now, what exactly happens is there is presence of allergy or autoimmune bodies formed to the glycoprotein adhesion molecules of desmosomes. You will find there is the intraepithelial split, and you will find that the epithelial cells will be split from the suprabasal compartment to the intravasal compartment, and this split can bring about a sort of changes that can be filled with fluid, and you will find that the lesion can be very well manifested in everywhere in the different parts of the body. It could be neck, it could be cheeks, it could be even the hands, the feet, anywhere in the body it can be manifested. There are 4 variants of pemphigus. You will find that pemphigus vulgaris, pemphigus foliaceus, pemphigus vegetans, and pemphigus erythematosus. They are supposed to be different situations. Sometimes you will find that there could be a paraneoplastic pemphigus, and sometimes it could be a drug-related pemphigus also could be manifested. Now, as I was telling you, there is auto antibodies formed to the desmosomes. Okay, that's the cause. Clinically, you will find that thin-walled bullas will be found, fluid-filled blisters will be found, apparently in oral mucosa, which is normal, or even the skin, and it spreads peripherally by extension. The bulla bursts and leads to raw bleeding surfaces, which we call that as Nikolsky's sign. If you press it in one area, it will flee to another area. So that's what's called as Nikolsky's sign. Application of pressure to the apparently normal skin can lead to a new lesion formation. In the oral cavity, you will find there is presence of classic bulla, which bursts to form what's called as candidiasis infection, and that could be associated with pemphigus vulgaris. So you can see the various lesions that are taking place on the palate, on the tongue surface, as well as the lip. It is a marked situations which can occur in the oral cavity. Now, of course, the laboratory investigation that usually we take is a biopsy, which is a very characteristic feature, and you can stain it with immunofluorescent stain, and that can give a beautiful IgG deposits between the keratinocytes of epithelium. Usually, under electron microscope, you will find the loss of intercellular cementing substance and destruction of the donor filaments or desmosomes. And you can notice that histologically in the H&E sections, you'll find there is a suprabasilar acantholysis. Lower layers of the spinosome will be intact. However, in the middle part, you'll find there is acantholysis, and the cells are round rather than polyhedral. You'll find the loss of intercellular bridges, and you can notice that the nuclei appears to be hyperchromatic. It's a characteristic feature which you can notice in the H&E as well as in the immunofluorescent staining. Beautiful picture. Okay. Now, how do you manage this situation? You will find that the situation can be from mild, moderate to severe situation, and depending upon the involvement, you may have to pump in a lot of steroids, high doses of steroids, about 1 to milligram per kilogram per body weight per day, and there should be tapering manner, should be given. Adjuvants like cyclophosphamide or azeoprone can be given. In many severe extreme cases, you can even give intravenous immunoglobulins in the form of interferons, and you can even give extracorporeal photopheresis or plasma exchange can be done. That could be a very useful tool. Yet another condition which I was telling you was paraneoplastic pemphigus, which is supposed to be very recently original, described by Anhalt et al. In 1990, supposed to be a lesion which is associated with neoplasm. Conditions like very severe and can produce blindness also. In the oral cavity, the large necrotic painful erosions are covering the lips, tongue and the soft palate can occur. Management is done by giving the patient with some prednisolone and immunosuppressive drugs, which could be helpful for the skin lesions. However, the patient with the involvement of the skin. In the oral cavity, how the lesions can manifest on the tongue, and finally, it's supposed to be a very, very dangerous condition. Now, as I was telling, it's supposed to be a bullous mucous membrane pemphigoid. It could be a group of autoimmune diseases where there will be a subepithelial bulla. There is a split in the basement membrane area where there will be a cleft formation between the epithelium and the lamina propria. In such a situation could be characterized by bullous pemphigoid if it is affecting the cutaneous the skin, and a cicatricial pemphigoid if it is affecting the oral mucosa. You will notice that situations can be of higher age group, and you will find
Paraneoplastic pemphigus is supposed to be another very severe form of pemphigus. It's associated with neoplasms, usually non-Hodgkin's lymphoma, chronic lymphocytic leukemia, thymoma are some situations which can bring about paraneoplastic pemphigus. This was described by Anhaltin et al. In 1990. Incidentally, here there is a very severe form of blistering that can take place and erosions can occur. It can occur even in the conjunctiva in the eyes as well as the oral cavity. In the mouth, you will find this very painful necrotic lesions that can occur on the lips, tongue and soft palate. Usually, such patients will have poor prognosis. Giving prednisolone or corticosteroids is the last way of treating such patients. Sometimes immunosuppressive drugs can also be helpful for skin lesions. You will find such a lesion can occur anywhere in the body, even in the oral cavity or on the skin, and you will find in the tongue also, you will find such a situation can occur. Well, this situation is to be monitored by different logic situations. Now, this pemphigoid is supposed to be a group of autoimmune diseases which can be characterized otherwise in the split between the epithelium and the connective tissue or the lamina propria. Now, this split is as a result of antigen-antibody reaction that can take place between the epithelium and the connective tissue in the lamina propria as well. So, if it is occurring in the skin, we call that as cutaneous lesions associated with bullous pemphigoid. If it is occurring in the oral cavity, you will call that as cicatricial pemphigoid. Now, bullous pemphigoid is supposed to be a condition which can occur anywhere in the age group of 60 years and above. It can last for a few months to over 5 years. This is supposed to be associated with an autoantibodies formation which is associated between the epithelium and the connective tissue, and you will find that that leads to transmembrane glycoprotein affected, which is supposed to be acting as antigens, and you will find that the hemidesmosomes, which is connecting the epithelium to the connective tissue, is affected. Now, the lesion usually occurs on an inflamed base. It can occur in the skin, on the scalp, the arms, legs, axilla, groin, and can rupture to form serpiginous ulcers. The oral finding can be manifested in the form of desquamatic gingivitis. You will find these lesions can be associated with inflammation, desquamation, and discrete vesicle formation. The lesions are smaller and chronic and less painful compared to that of pemphigus vulgaris. You can see the lesions, how they are fluid-filled, blisters are present on the skin surface. You can see in the oral cavity also there is associated changes that are taking place on the attached gingiva. Usually this condition is associated with postmenopausal situations in the oral cavity, and women above 45 years or 50 years will find the patient complains of severe amount of burning sensation. Patient is unable to brush her teeth. There is a lot of food debris accumulation. You will find bad breath from the mouth, and such patients will come to you for treatment, and it's a characteristic situation which is pemphigoid or bullous mucous membrane pemphigus. Well, when you do a laboratory investigation, you will find a direct immunofluorescence study. There is a linear band of IgG and C3 complexes in the basement membrane where you will find the lesion is actually present. This basement membrane is supposed to be the junction between the epithelium and the connective tissue. You will be finding a salt split skin technique which can be associated with IgG antibodies, and there is an epidermal side of the situation also. And histologically, you will find the separation of epithelium occurring, and you will find that there is a dense infiltrate of inflammatory cells comprising of eosinophils present in the junction of epithelium and connective tissue.
You can see the beautiful band that is separating the epithelium and connective tissue here, which is associated with the reaction, and that's a classic situation which is supposed to be pemphigoid. How do you treat? You are giving topical steroids in the form of betamethasone ointment or in the form of clobesterol, or in many severe situations you may give systemic steroids also for such patients. Mucous membrane pemphigoid, or what's called a cicatricial pemphigoid, is supposed to be again an autoimmune condition where you will find these autoimmune antibodies formed at the basement membrane proteins. You will find there's a junction between the epithelium and the connective tissue. It's called the lamina lucida, which is supposed to be affected. You find that type 7 collagen, which is the epidermal site, is affected, and there's usually a BP of 180, and many a times you see IgG is affected. Epiglerin, which is supposed to be laminin 5, a lamina lucida protein. And addition, a molecule of anchoring filament of basement membrane and beta 4 integrins are associated. This is how the relationship of MMPs with epiglerin has been linked to the underlying malignancy also. There are 5 subtypes of cicatricial pemphigoid: oral pemphigoid, anti-epiglerin pemphigoid, anti-BP, antigen pemphigoid, mucosal pemphigoid, ocular pemphigoid, and multi-antigen pemphigoid. Now, situations, as I was telling you, could bring about lesions where in the mucosa. It could be oral mucosa, conjunctiva, genital mucosa, or even the eyes, which can be associated with such lesions, can bring about blindness also. Oral findings would be manifested in the form of desquamated gingivitis. There will be thick bulla, thick roof will be there. It bursts in about 2 to 3 days, and formation of such situation can bring about ulceration also. Erosion spreads slowly as compared to pemphigus vulgaris. However, the healing is much better and can take. There is changes that are taking place in the eyes. We will find how the cicatricial pemphigoid behaves, and these lesions are very much painful, and patient can go even for blindness because of the involvement of conjunctiva, and even corneal ulceration can take place, and such situation can be of very nasty situations. In the oral cavity, the desquamative gingivitis can be associated with bulla formation. There is a thickness of this bulla because it is leading to ulceration also after bursting in 2 to 3 days time. However, the healing is much better compared to that of pemphigus vulgaris, and you will find that it can spread, it can heal between 3 weeks to 4 weeks, the duration time. Now, here is a situation in the oral cavity where the pemphigoid can occur in the form of bullous mucous membrane. Okay, you can see the lesions that are occurring in the premolar and canine areas. Now, what investigation you would like to do for pemphigoid or bullous mucous membrane pemphigoid is a character situations. We will find the edge of the ulcer can be seen. We will find that direct immunofluorescence can show you an IgG or an IgC3 basement membrane zone. Lesions can be present, and you will find you manage it by topical steroids and intralesional steroids and using betamethasone. Severe cases can be provided with systemic steroids. Adjuvant therapy, sometimes you may give tetracyclines and dapsone to prevent any supra-infection. There is a beautiful split that is taking place between the epithelium and the connective tissue. The junction of the basement membrane, you will find the lesion is something like a hairpin type of lesions which can occur in the oral cavity. Well, the third and the last one which I would like to talk to you is the linear IgA disease, which is supposed to be another condition which is characterized by sort of irritation to the gastric mucosa or the duodenum, which is associated with glutons, and such a situation can occur even in the oral cavity, which is associated with
subepithelial disease where deposition of IgA rather than IgG is associated at the basement membrane zone. This is maybe associated with drug reaction also, or maybe associated due to hematological malignancies. Now you can see how the lesion can occur in the marginal gingiva, in the attached gingiva, as well as in the alveolar mucosa. Now situations can be associated with pruritic macules, which will be form blisters and can bring about a thinning of the mucosa, and ulceration can take place. It can be manifested even in the knees and the elbows. And the oral findings could be one which is very similar in the form of vesiculobullous rashes. Histologically, you will find that there is a different direct immunofluorescence showing a deposition of IgA instead of IgG, and the characteristic subepithelial lesion is a manifestation. The histological picture is almost similar to oral lichen planus. The management is done by topical steroids following Dapsone therapy could be of a great help. Now, oral lichen planus is supposed to be a very, very common disease among the women population. At the ratio of 2:1, the females are affected, and is more characteristic in females above 50 years of age. It could be as a result of stress and strain. It could be also due to hormonal imbalances. But however, etiopathogenesis could be associated as a result of immune system, which plays a primary role. And there is a subepithelial band of infiltrate. You find the presence of chronic inflammatory cells just adjacent to the connective tissue lamina propria, adjacent to the basement membrane. You'll find there's more of T lymphocytes and macrophages, which is also characterized by liquefaction degeneration of the basal cells. As I was telling you, it may be attributed to the stress. You will find that especially high strength individuals are more prone for lichen planus. The lesions could be of different manifestations. It could be a reticular type, it could be a papillary type, it could be a plaque type, it could be a bullous type, it could be a erythematous type, or it could be an ulcerative type. Clinical form depends upon the amount of underlying inflammation that is present. The milder the inflammation, the hyperkeratotic lesion will be more seen. If the inflammation is severe, you will find there is atrophic or erosive type of or ulcerative type of lesions that can be found. You can see all the different types of lesions that can be found: bullous, ulcerative, plaque-like, papillary type, and reticular type. Usually, the main characteristic feature of lichen planus is the presence of reticular type, where you find a small network of white band of structure that is present. We call it as Wickham striae or striae of Wickham. These white lines show the erythematous zone at the periphery. Usually, this network will be characterized and that will be annular in nature, and the plaque type can be manifested later on in the form of leukoplakia as well. Usually the common lesions that occur in the oral cavity is in the buccal mucosa, and another characteristic feature of lichen planus is that it is bilaterally symmetrical. If it is present on the right side, it will be present on the left side also. The lesions could be, as I was telling you, reticular, papillary or plaque type. Usually it will be asymptomatic in nature. But as the time passes on, you can find that there could be erythematous type, the buccal mucosa or the hard palate, attached gingiva, all these areas can be involved. And ulcerative type, where it will be more disabling, which can be marked with central inflammation, with peripheral and radiating white striae, and such lesions could be found leading to more pain and discomfort and burning sensation in the mouth when the patient comes to you for treatment. Even you can find cutaneous lesions of lichen planus, especially in the arms and the extremities, especially in the knees as well as in the elbows, which can be in the form of pruritic macules and papules on the flexor surfaces of arms and legs. So we are going to talk to you the histopathological changes that are occurring in the oral lichen planus. You will find that in the epithelium,
there will be sawtooth retipex, which is a characteristic feature of the lichen planus. The presence of hyperparaskeratosis and orthokeratosis are the characteristic again situations. You will find in the connective tissue there is liquefaction necrosis, and there is a band of fibrin deposits that can take place in the connective tissue. Presence of eosinophilic cytoid bodies or civet bodies is again a wonderful example of situations like that. You will find there is presence of dense inflammatory infiltrate of chronic inflammatory cells that are present, and thus again a revealing feature. When you talk about the immunopathology, you will find in direct immunofluorescence the linear deposition of fibrillar deposits and immunoglobulin staining cytoid bodies which can be found. How do you manage the lichen planus? Is by giving drugs which are especially steroid-like or cyclophosphamide type or tacrolimus retinoids, which could be of great help. Usually vitamin A therapy is supposed to be a very good helpful one to treat such a patient with lichen planus, because it will improve the epithelial and the epidermal conductions. Even ultraviolet phototherapy has been advocated. Well, symptomatic forms can be treated by fluoxetine. There's an ointment which can be applied on the surface 3 times a day. Even sometimes a tray can be prepared. Now that tray can be used in the form of 0.5 clovestrol propionate with a 1 lakh in IU per ml of nystatin in the form of ora base can be useful. Intralesional injections of triamcinolone acetonide can be used for local application. Now here is a situation where you will find there is a presence of characteristic immunofluorescence staining. There is at the junction you will find there is a presence of these lesions that are present in the form of cytoid bodies. Well, sometimes you may have to prescribe anti-steroids which are supposed to be prednisolone, which is 40 milligrams for a period of 5 days, and then you taper it down to 10 to 20 milligrams for 2 weeks in many severe cases. Otherwise, you can prescribe, as I was telling you, retinoids or vitamin A, and you can prescribe hydroxychloroquine, even cyclosporine. Many situations can be done. Even sometimes antifungal agents like candidiasis can be prescribed. Many a times people think of even giving free gingival grafts if it is associated with the gingival lesions, and giving the drug as a theoprene, which could be of a great use. Tacrolimus is supposed to be a new drug which is 1.1% ointment, is very promising. Well, there's another situation which can be called as lichenoid drug reactions. Now, lichenoid drug reactions are associated with delayed hypersensitivity reactions to certain drugs or certain substances which are being given to the patient. Sometimes, penicillins or gold or sulfonamides, which can bring about such a delayed hypersensitivity reaction, or drugs or metabolites can be associated. Sometimes even that filling that we used to do regarding the silver fillings, that could bring about a lichenoid reaction also, because of the presence of silver and mercury in the filling materials. Cell proteins presented by the antigen presenting cells are associated with the T lymphocytes. You will find drug eruptions are similar to that of oral lichen planus and may be severely pruritic. And the situation can be managed by discontinuation of the drug, and topical steroid application could be of great use. Now here is a situation where you will find the lesions can be associated on the tongue, which could be a characteristic feature of such a reaction. Chronic ulcerative stomatitis. Ulcerative stomatitis is a very common feature
in many people, and that could be associated with painful, solitary blisters, erosions in the erythema, which could be associated with the gingiva, and can be a very, very characteristic feature. When we do the laboratory investigations, and we will find that there is perilesional sites and normal sites could be differentiated in the direct immunofluorescence. However, in the histopathology findings, we will find that stratified epithelium, specific anti-nuclear antibodies, SES, ANA could be found. The IgG deposits in the nuclei are in a speckled pattern. Now, the fibrin deposits at the epithelial connective tissue interface could be of a very, very useful situation. Now, here is the situation which is found, where characteristic lesions can be found in the IgG deposits and the nuclei. Dermatitis herpetiformis, found in young individuals. They are around 20 to 30 years of age, and there's more male can be affected. You will find there's a cutaneous manifestation of celiac disease, and this is associated due to tissue transglutaminase, and that autoantigen could be associated. And you will find the intestines, the skin, the mucosae are all could be associated. This could be associated as a result of gluten enteropathy, especially when you take wheat. There's different type of wheat is available, red wheat and the brown wheat, or yellow, white wheat. Now if you take the brown color wheat, that is supposed to contain more of gluten, and that can bring about such a satiation. Now, what do you find in the oral cavity? There will be pruritic, papillovesicular lesions symmetrically present. Now, laboratory investigations will find that presence of IgA and C3 deposits in the dermal papillary physis. About 80% of the patients show anti-endomysial and gliadin antibodies. The foci of neutrophils and eosinophils among the deposits of the fibrin at the dermal apex could be manifested. Now, here is a situation where will be the dermatitis herpetiformis, which could be manifested by using different staining techniques. Okay, as a matter of fact, we'll find these lesions are more characterized by the IgG antibody. Lupus erythematosus, or LE, is supposed to be again an autoimmune disease, which is usually found in the two forms, systemic type or a localized type, and could be chronic in nature, acute in nature, or it could be subacute in nature. Now, systemic lupus erythematosus could be a multi-organ disease, can manifest in the heart, kidney, skin, or oral cavity, and usually the females are more affected than men, usually at the ratio of 10:1. And these lesions would be found usually characterized by fever, weight loss, arthritis. Now, classic cutaneous lesion will be found on the face. We find a butterfly-shaped lesion which will be present on the cheek mucosa on the surface of the skin, and it will be found across the bridge of the nose and rash on the malar areas. In the oral cavity, we will find the oral lesions could be similar to that of oral lichen planus, and when we investigate, we will find the presence of IgG and IC3 deposits, which could be found in the dermal epidermal interface. Now, you can even find anti-nuclear antibodies, ANA, present in 95% of the cases. Even DNA extractable nuclear antigen, ENA, antibodies are present in the more than 50% of these conditions. Now, here is a butterfly type of lesion, which is characteristic feature of lupus erythematosus. Now, chronic cutaneous lupus erythematosus could be of different type. Could be a component of mucosa, or it could be a component of skin. We call it as discoid lupus erythematosus when the lesion can occur in the skin, leading to atrophy and chronic scarring. Or it could be a plaque-like, a thick lichen planus lesion which could be present.
Now the lesion, usually the center of the lesion is depressed, they're covered by a thin bluish red epithelium. Surrounding the erythematous base areas are replaced by whitish or bluish white peripheral zone of thickened epithelium. You can notice the lesion of the skin on the surface of the cheek, and you can see the angle of the mouth. You'll find how the lesion is so abruptly changing. Even in the oral mucosa, you can find the similar lesions where you will find typical crust, scales, and pinhead bleeding spots could be found even in the oral cavity. Now, laboratory investigations, as I was telling you, the different direct immunofluorescence study will lead to lesional and perilesional tissue, not the normal tissue one, but the different ones. You'll find IgG and C3 deposits at the dermal epidermal junctions. Indirect immunofluorescence, as I was telling you, ANA is shown in 95% of cases, and DNA, ENA, circulating antibodies in 50% of cases. Hyperkeratosis, parakeratosis are all the lesions which can be found. Alternated acanthosis and or atrophy or the hydropic degeneration of basal layers could be manifested. There is yet another situation which could be called as subacute type of cutaneous erythematosus, where you will find the typical DLE lesions but do not show any scarring. However, the laboratory investigation shows that IgG and C3 deposits of the dermal epidermal junctions in 60% of cases. You find granular IgG deposits in the cytoplasm, and you will find about 80% of patients having the SSA antibodies to nuclear antigens. Rheumatoid factors could be also found in about 10% of cases, and about 10% will have anti-ribonucleoprotein, which is called as anti-RNP antibodies to nuclear antigens. Well, how do you manage? Here's a situation again, use of steroids. You can be giving topical steroids, okay, or sunscreens, and arthritis and pruritus could be treated by NSAIDs. Severe type of organ involvement could be associated with steroids. Severe cases can be even supported with immunosuppressive drugs. Usually the lupus erythematosus can manifest it in the form of discoid lupus erythematosus in the kidneys, which is a very common feature. Psoriasis, again a dermatological lesion which is very characteristic, found with the leading to inflamed edematous skin lesions covered with silvery white scales, and the cause of this condition could be a genetic predisposition where you will find HLA-CW6 and HLA-B57 could be associated. Now, apart from that, you will find there could be associated HIV, or it could be stress, or it could be seasonal variations which can take place. Usually psoriasis occur more in the seasonal region, especially in the winter, and such people are more prone for itching sensation. Now, usually as a pathogenesis, the increased turnover of rate of dermal cells can take place. You will find epidermal cells which normally turns over for 23 days, it runs up very fast for a 5-day period. And such lesions which will be characterized by small, sharply delineated dry papules and covered by silvery white scales, and you will find a thin layer of mica-like lesions which could be scraped out from the skin surfaces. Removal of the scale will lead to tiny bleeding points, which is called as Aspit's sign. Now, in the oral cavity, you will find there could be yellowish white plaques, silvery white scales, and multiple papular lesions. Even the tongue could be affected, leading to fissured tongue, or it could be a geographic tongue. Now, you will notice that in histology, you will find presence of parakeratosis, you will find there is absence of stratum granulosum, you can find clubbing of retapex, you can find also sometimes intraepithelial abscess formation, which we call it as Munro's abscess, and the management can be done by ultraviolet light, okay, placement, or sometimes Soralin plus ultraviolet light, which could be of great help. Sometimes even prescription of retinoids or vitamin A, which will be very helpful. Now here is a situation where psoriasis could be very beautifully manifested, shown in the picture, typical of test tube shaped retipex, which is a feature of psoriasis. Now, well, something about the conclusions, we can notice that these are all the lesions which we have taken from different textbooks, and we have given a presentation. Okay, thank you very much.